Yes.
All right.
Excellent.
Okay, excellent. See, that worked. We just like magic. Here we are. And I'm going to make sure that I actually turn on the screens, and I believe that everybody's in here. Okay. All right, well, let's kick this sucker off and just get this party started. Hi, everybody. My name is Terri Conneran, and I'm with KRAS Kickers. And I am like really excited to be here today. We just had an amazing meeting at AACR, which is the, let's see, American, okay, I should know this. Like, what is it? AACR, American something. What's it stand for? I forget.
Association for Cancer Research.
American Association for Cancer Researchers. Yeah, okay. All right, one more time. Hi, I'm Terri Conneran with KRAS Kickers, and welcome to March 2024. We're going to be doing a summary of the American Association for Cancer Researchers 2024, and today I'm delighted to have us. I'm Dr. Ferdinando Skoulidas from MD Anderson. But first, before I forget, the reason we're able to bring this to people for free, without any cost, without hounding you for money or begging for bucks at all, is because of the generosity of our sponsors. And so first and foremost, I must just thank them. Just a one-time shout out to Amgen, Genentech, which is part of Roche, AstraZeneca, Mirati Therapeutics, which is now owned by BMS. And we have some supporting sponsors as well with Loxo Lilly, Novartis, and Sanofi. And so thank you guys for what it is you're doing. Welcome today to having you back today. Last year we had you do the 2023 highlights. And this year, I hope you're prepared for questions. You ready to roll?
Absolutely, absolutely. I made special preparation for questions this year. Well,
Okay.
it's an absolute pleasure to be joining you, Terri, and the KRAS Kickers. Thank you for having me back. It was certainly a very busy and productive meeting. Lots to talk about, as always. I'm going to try to put things into a perspective. So we're not just going to talk about what was presented at the AACR. I'm going to give a kind of an overview, and then I will interject the new data that was presented at the AACR and try to put it in context. But I think we've got an hour and a half, so we've got plenty of time for questions. I've tried to make things as clinically relevant as possible for the kickers. But I have, I'm a physician scientist, so I have entered, a fair bit of science in there as well. So feel free to stop me at any time point and ask me all the tough questions. If there's something you guys don't understand, we won't let it go. We will not proceed to the next one until it's completely understood. All right, ready to rock and roll? All right, I'll share the screen with you. All right, then let's put it into a slideshow from the beginning. All right, you should be able to see it. Okay, so we're going to be talking about targeting KRAS, and we're going to give an overview, as I mentioned, and we're going to provide an update for what happened at AACR. My name is Ferdinando Skoulidas, and I am an associate professor in thoracic oncology at MD Anderson Cancer Center, and a proud KRAS Kicker kind of member. All right, so this is my disclosure information. Okay, so we're going to start with what is known. We're going to very briefly talk about the two inactive state selective KRAS G12C inhibitors that in a way kick-started the entire field of being able to directly target KRAS. We all know that targeting RAS in general has been one of the biggest challenges in targeted cancer therapy. For more than 30 years, it was considered, despite multiple efforts, it was considered the perhaps undruggable target. But we all know, largely due to the pioneering work by Dr. Shaukat, we now know that targeting RAS mutant alleles directly is possible. So there are now two drugs that have received accelerated approval for targeting KRAS G12C mutated non-small cell lung cancer that is previously treated with at least one standard of care systemic therapy. These are sotorasib, and I had the privilege to play a role in the clinical development of sotorasib, where based on the results of the CodeBreak 100 clinical trial, the objective response rate, as you know, is around 37%, with a median overall survival about 12.5 months and a median progression-free survival at around 7 months. And then we also have adagrasib, that again has received accelerated approval for KRAS G12C mutant non-small cell lung cancer based on the results of the Crystal-1 study, where the objective response rate was 43%, the median overall survival approximately the same, 12.6 months, median progression-free survival 6.5 months. So that's fantastic news. These drugs have proven beyond any doubt that the targeting KRAS is possible. However, we all acknowledge that there is more that needs to be done, because the median progression-free survival with both sotorasib and adagrasib is around the 7-month time point, which of course is not optimal. It suggests that there are some patients that derive less benefit from these drugs, and there are some patients that derive more benefit from these drugs. So clinical responses are heterogeneous. Now, one question that always comes up, I think, when we present KRAS talks is, well, okay, there are now 2 drugs that have received accelerated approval. How do you make a choice? How do physicians decide on an individual patient basis which one of the 2 drugs to prescribe? And the 2 drugs, as I mentioned, have got comparable efficacy. The median PFS around 7 months, median overall survival 12.5, 13 months. So how do we choose? Well, a number of factors come into play when trying to make the best decision for an individual patient. And every physician will use, slightly perhaps their own different criteria, will weigh differently. I will tell you what I do. So I'm happy to use both drugs. I think both drugs I consider effective and safe. I think for patients where I have some concern regarding the performance status of the patient when they start treatment, perhaps these patients have previously had a rough time with chemotherapy, and their performance status, they might be fatigued, their performance status might not be that great, they might have suffered in particular gastrointestinal related adverse events. In a scenario like this, I might favor sotorasib, because the rate of gastrointestinal treatment related adverse events with sotorasib appears to be a little smaller. So in these scenarios, I would choose sotorasib. The other scenario where I might choose sotorasib over adagrasib is if the patient's medication list, I will go through the patient's medication list and try to look for potential drugs that might be interacting with either sotorasib or adagrasib. And in this case, adagrasib has got more drug-drug interactions that one needs to be aware of compared to sotorasib, particularly with regards to drugs that might be prolonging the QTc interval. So if someone is on a number of different cardiac drugs, have got a history of cardiac disease, and are on drugs that may prolong the QT interval, that's a scenario where, again, I might favor sotorasib. What are scenarios where I might favor adagrasib? Scenarios where I might favor adagrasib are in patients who have brain metastases, small brain metastases that have not been previously treated. And that's because although both drugs have shown to different extents intracranial activity, I think the data regarding the intracranial activity of adagrasib, particularly in patients who have previously untreated brain metastases, is more robust. The intracranial response rate with adagrasib in that scenario, and that I think is what's coming here, is in the region of 33 to 40%, and that includes patients both with previously treated brain metastases as well as patients with previously untreated brain metastases. So this is a scenario where I believe that the data is more robust for adagrasib, and I might favor that. The other scenario where I might favor adagrasib is in the context of a patient who has previously had hepatotoxicity with first-line therapy, particularly immune-related hepatotoxicity. If someone's liver tests have gone up during prior treatment with immune checkpoint inhibitors, especially if that patient has just very recently been receiving immune checkpoint inhibitor therapy and is now switching to a G12C inhibitor, I think that is a scenario where, again, I might favor adagrasib, because and we'll talk about this in more detail later when we talk about the combinations with immunotherapy. But one of the well-recognized adverse events with off-state selective inhibitors is hepatotoxicity. And this hepatotoxicity is believed to be immune-mediated to some extent. And therefore, patients that have most recently received immune checkpoint inhibitors are at greater risk of developing immune-related hepatotoxicity with these drugs. And sotorasib in this case has been associated with higher rates of hepatotoxicity. So in a scenario like this, I might favor, adagrasib. This is the data regarding.
All right. I just let you just roll way too long. You know, be better than that.
Okay.
I have questions.
Go for it.
So first of all, let's. Okay, I know you're used to presenting to, like, to the who's who in cancer. So let's roll it back a little bit. When you're talking about toxicities, okay, you're talking about liver issues. Okay, correct? Okay.
Correct.
Liver issues. Why is that important?
Well, that is important because it's one of the major toxicities with the drug, and obviously the liver is a critical organ. It's a kind of, if someone develops severe liver toxicity, that is something that can be a serious adverse event. Now, it is particularly important here because there seems to be an interaction between the development of liver toxicity from the G12C inhibitors and prior treatment with immune checkpoint inhibitors. So patients that have received an immune checkpoint inhibitor within the prior 30 days are at greater risk of developing immune-related hepatotoxicity, and this seems to be particularly a greater problem with sotorasib than with adagrasib. Okay, so that's one of the things that
hang on. Sorry. Okay, you said I could interrupt. You
Yes.
would expect this. Okay, so you're saying within 30, so you may think you've got lots of time here, but we've got lots of ground to cover. 30 days within having immunotherapy, and immunotherapy, which is a checkpoint inhibitor, okay, is tough on our liver. We only have one liver, right, in our body, right?
That's
okay.
Right.
Well, hey, it's been a hot minute since I've had biology. Okay. So we have one liver in our body, and that's what's processing all the stuff that it is that we're putting through our bodies. Correct? Okay.
Correct.
And so it's looking as though if you have, say, ongoing liver issues, or you've been on immunotherapy within 30 days, sotorasib may be a lesser choice than the adagrasib. Is that correct?
I think if someone has had previous problems with immune-related toxicities from the liver, so the liver tests going up during previous therapy with immune checkpoint inhibitor, and they've just come off the immune checkpoint inhibitor, yes, that's one scenario where I would, I might favor adagrasib.
Okay, and then when would a time be that you would favor sotorasib? Scroll back. I understand robust studies and whatever. So, but scroll it back. When would be one time that you would favor the other?
I would favor sotorasib in the context of someone who has a lot of GI toxicity. Say someone is already complaining of nausea, diarrhea, has got previous gastrointestinal disorders that might predispose them to these GI toxicities, as well as generally in patients who might not be, whose performance status might not be, might be a little bit borderline. We call this performance status 2. Performance status 2 means someone who is kind of not able to do all activities of daily living as they would normally do. They spend probably less than 50% of the awake hours sitting on a chair or lying in a bed. So these are the patients that we ask them, how are you doing? And they say, I feel fatigued. I've got some side effects. I'm not able to do what I used to do. So those are the patients where, with a more borderline performance status, I usually choose sotorasib for those patients.
So just hang on with me. Okay. So when I'm going in and I'm reporting out how I'm feeling to you as my doctor, I'm coming in and I'm like, I'm tired, I'm beat up, I'm worn out. Okay. Are you like, well, what do you mean by that? Or does that make me from a 1 to a 2? You're listening for that. What I'm kind of trying to get to is you're listening for that information to help gauge what my better treatment decision would be. That's kind of where I'm going with.
Absolutely. So I would rely first of all on the information that you offer, spontaneously, and then I would ask more direct questions. I would perhaps ask you, are you able to do everything that you want to do? How far are you able to walk? What are you able to perform all activities of daily living, cooking, dressing, shopping, cleaning, those kind of questions, and how much time from the awake hours, let's say from morning to evening, what fraction of your every day do you spend perhaps being active versus sitting on a chair or watching TV or being inactive? And if that is, if someone is active, able to do pretty much everything that they want, that is usually, we code that as performance status 0 or 1. If someone says I'm spending 50% of the day or 40% of the awake hours sitting on a chair, I'm not able to do my shopping, I need help with this might point towards a more borderline performance status. And that is the patient where I feel that they're more fragile in a way. And potentially that would be a better candidate for sotorasib.
Okay, that's good. Now, are community oncologists generally informed of this sort of thing with immunotherapy and the targeted therapy?
I think there is growing awareness. I think one of the statements in the license for sotorasib is that very careful monitoring of liver function tests is necessary, and it needs to be done every 3 weeks for the first 3 months of treatment. And that is important because in many cases, this hepatotoxicity can be delayed. In other words, you do not see it immediately after someone starts treatment with sotorasib or adagrasib. It might take several weeks. It might not be until the second or the third cycle of treatment that suddenly you see the liver tests start to go up. But from the time that they go up, if that's when it's important to pick it up early, and depending on how severe the level of the liver test abnormality is, you would either have to stop the drug straight away and wait. Sometimes, wait until they improve. Sometimes your doctor might prescribe steroids to try to get the liver tests to come back perhaps a little faster. In many cases they will go down, and then depending on whether they've gone down and how bad they were to start with, they might advise you to restart it or to cut the dose. But it's kind of quite important during that time, first of all, to pick it up early. And secondly, once you've picked it up, depending on the severity, to either stop the drug or monitor it very, very, very carefully to make sure that it doesn't go up more rapidly. So either way, very careful monitoring of liver tests every 3 weeks for at least the first 3 months, and thereafter as necessary, is mandatory when someone starts all G12C inhibitors. Now, if someone has in the recent past received an immune checkpoint inhibitor, that becomes even more pertinent. It's even more important to monitor LFTs very carefully in that setting.
Okay. From a practical standpoint, is there a way that I can improve? Okay, you probably get this question a lot. Is there a way that I can improve my liver function? Or what is the sort of thing that I should be looking for? I mean, I do remember that people will turn yellow, right? If you have a real big liver problem, but is there like some precursor warning besides just a blood test?
Not really. I think the things to be aware of, obviously, if you develop any symptoms, let's say you develop right upper quadrant pain right underneath your right rib cage, I mean, that would certainly be a worrying sign. If you develop symptoms of liver dysfunction can be non-specific. So someone can have pain, they can have nausea, they can have vomiting. There are more specific symptoms such as turning yellow, which of course, or your urine turning dark, which are of course indicators of more severe liver dysfunction. So hopefully we will catch it, before that. But those are things that certainly are worth reporting immediately. It's also important to go through what I would say. It's important to go through your list of other medications with your physician, because there are a lot of drugs. Antibiotics sometimes can cause liver dysfunction. There are a lot of other drugs that can cause abnormalities in liver tests, and in the context of recent initiation of sotorasib or adagrasib, it might be difficult to know what's caused what. So it's generally a good idea is to try to avoid drugs that might also be associated with abnormal liver tests or hepatotoxicity when you're starting these drugs.
Okay, and last question on this slide, I promise you. Okay, and so is my oncologist going to know all that about the interactions of the drugs, or is that really something I need to get like a pharmacist oncologist involved?
I think a pharmacist would definitely help. I think many of these interactions are known or are described in the label, but oncologists, especially community oncologists, deal with many different tumor types, many different drugs, multiple new drugs. So I think it's always a very good idea to kind of to have your PharmD go through the list of medications that one is taking, and that's particularly even more relevant, I would say, for adagrasib than with sotorasib, because that's the one that has a wider spectrum of drug interactions and especially cardiac medication as well, or drugs that can prolong the QT interval. So I would say definitely engage your PharmD to go through the drugs, your pharmacist carefully with you when you're starting a G12C inhibitor. All right. Okay. All right. So we moved on. We spoke about the intracranial activity of both drugs, and as I mentioned, both drugs have been reported to have activity, but perhaps the data is a bit more mature, a bit more robust for adagrasib than with sotorasib. This is the data for sotorasib, also showing that there appears to be some evidence of intracranial activity from the CodeBreak study. And we mentioned the registrational trials that led to the accelerated approvals. I would like to point out that we do have the CodeBreak 200 clinical trial, which was the first randomized clinical trial, phase 3 clinical trial, to compare sotorasib with docetaxel for previously treated patients with advanced KRAS G12C mutant non-small cell lung cancer. This was a positive study. It met its primary endpoint. Sotorasib resulted in a 34% reduction in the risk of progression or death compared with docetaxel. However, there was no apparent overall survival benefit with sotorasib compared with docetaxel. And we recently saw that the FDA raised some concerns about the strength of the evidence supporting in the analysis of the primary endpoint. So there will be additional studies required to validate the benefit of sotorasib in this context. However, both sotorasib and adagrasib at this point in time have got accelerated approval. Now, this is a new development, and this is an exciting development. Bristol Myers Squibb recently announced that the pivotal Crystal 12 clinical trial, which is a phase 3 clinical trial that compares adagrasib now with docetaxel for patients with previously treated advanced KRAS G12C mutant non-small cell lung cancer, met its primary endpoint, which was progression-free survival. So this was a positive study. This was a press release. We have not seen more detailed data. We do not yet know whether adagrasib also prolongs overall survival compared with docetaxel, but we do know that this was a positive study that met its primary endpoint. So we look forward to these results, to the results of the Crystal 12 phase 3 clinical trial in the near future. But this is certainly good news for patients.
Okay, all right, hang on. Oh, well, I do want to hear about the divarasib too.
Yeah.
Okay.
So
hang on 1
sotorasib
second. Wait. Sorry, I'm sorry. Okay,
Go
you know
for
I'm
it.
just gonna bounce out of my chair. Okay, so and I'm not sure if I haven't seen your slides already, so I apologize if I'm kind of throwing your role here, which I know already that I'm doing. Why would somebody want to do a targeted therapy versus chemo? Okay. And how does that lay out? And are you going to kind of cover that after we go through all the G12C inhibitors?
Yeah, it's an excellent point. So both sotorasib and adagrasib received accelerated approval. So these are, a fast track to regulatory approval on the basis of objective response rate and durability of response that was shown in the initial phase 2 clinical trials, which was CodeBreak 100 for sotorasib and Crystal 1 for adagrasib. However, For a trial, for a drug to get full approval, then it needs to also have confirmatory results in the context of a randomized phase 3 clinical trial with many more patients, where the new agent, the investigational agent, is being compared with the standard of care, which prior to the development of G12C inhibitors was docetaxel or docetaxel plus ramucirumab. So this is an important consideration when the FDA considers whether to grant full approval to a drug. So as we saw in Codebreak 200, which was the confirmatory study for sotorasib, there was a PFS benefit, so the primary endpoint was met. However, the trial did not show an overall survival benefit. And there were some questions raised by the FDA. There was an ODAC last year where the assessment of the primary endpoint was deemed unreliable. So I think it's quite important to get confirmatory data in the context of a randomized phase 3 clinical trial when we are trying to assess the efficacy of a new drug compared to the standard of care. So now I completely understand your point. The Codebreak, and I share the points. I think we were all watching the ODAC together, and I saw your intervention at the ODAC. So at the level of an individual patient, a 34% reduction in the risk of progression or death, which with a pill that doesn't involve losing your hair or suffering some of the side effects that are associated with docetaxel, and improved quality of life is an important consideration. So I certainly understand why you raised the question. However, I think it is important to conduct a clinical trial in the clinical evaluation of new drugs in a standardized way. So I think that conducting randomized phase 3 clinical trials to definitively assess the magnitude of the benefit for a targeted agent versus the standard of care is still the standard way that new drugs are approved, and we should adhere to it.
From a practical standpoint, again, you really think you're going to get through all this today, and we both know you're not. But from a practical standpoint, can I take a G12C inhibitor, okay, and then go on a docetaxel, or should I take docetaxel and then go on a G12C inhibitor?
That's a good point. I absolutely recommend to my patients to start with a G12C inhibitor before moving to docetaxel, because I think that both drugs have got accelerated approval in this context. There is no doubt with regards to that their tolerability is better than that of docetaxel, and both drugs have shown progression-free survival benefit in the context of randomized phase 3 clinical trials. So I would recommend a G12C inhibitor over docetaxel, and to my patients any day of the week.
Because because if you're going to respond to it, you have a better chance of responding to it, or because it's easier on our body and it's easier to go from a pill or a handful of pills to chemo.
For both reasons, I think that these are drugs that are active. The trials, both trials appear to have been positive. And we don't know what the overall whether there is an overall survival benefit, which is critically important. But even progression-free survival benefit with a drug that is less toxic and better tolerated and much more convenient for patients is, I think, a very meaningful improvement. So I absolutely recommend my patients to go to a G12C inhibitor prior to moving to docetaxel.
Okay, but if I had been on docetaxel, okay, as a patient, if I was on dosi, would it be easy for me or more complicated for me to get onto a G12C inhibitor? Say I was seeing another physician or something, and this was just kind of like they were like.
I don't think that that would be a particular problem. It is important to give our best treatments earlier, because there are always some patients that for whatever reason their conditions deteriorates, their tumor grows faster, and then they lose the opportunity to move to the next drug. So I personally always believe that it's better to give what you believe is best sooner. in the context of lung cancer. However, yes, to answer your question, someone who has previously received docetaxel or docetaxel ramucirumab can still be prescribed sotorasib, and there are no issues with coverage of the drug in that context that I have encountered.
And as it relates to it, and then I want you to go into the DVA after this question. Would there ever be a reason to re-challenge with immunotherapy?
To be re-challenged with
immunotherapy, even if it's a different type of immunotherapy?
Yeah, these drugs are there are no there is no kind of approval in that context, right now, but there are studies being conducted that the Pragmatica study, that assesses, combining an anti-angiogenic agent together with immunotherapy in patients that have previously failed an immunotherapy. So that is something that may well come in the future, and it may well be something that certain physicians are able to, do. I don't think we've got definitive data at this point in time that this is a favorable approach, but it is something that it's a good question, and it is a valid point, and it is something that may find its way. I certainly don't think that once you've had a G12C inhibitor and in a way it's out of your system, if you want, there should not be any additional concerns regarding hepatotoxicity from using an immune checkpoint inhibitor. So this only really happens in someone who has previously had an immunotherapy and gets the G12C inhibitor. If you finished with your G12C inhibitor and then you go to immunotherapy, the expectation is that this does not, at least I have seen no studies that this results in an increased risk of adverse events in that context.
Okay, and one more. I just can't contain myself. Can you change if your drug is not working, your G12C inhibitor is not working? Can you change treatment? Can you go to the other one of the other inhibitors?
Yeah, that's a good question. There is currently no convincing rationale to do this outside situations. So one situation where you might do that is, let's say you have been on sotorasib and you have developed hepatotoxicity in the context of recent immune checkpoint inhibitor therapy, and it subsides, and your physician is concerned about re-challenging you. Let's say that they have tried with a lower dose and it still happens. That's one scenario where I think trying adagrasib is reasonable. But in the context of a tumor, outside of treatment-related adverse events, in the context of a tumor that has where the sotorasib has stopped working, or where adagrasib has stopped working, there is no overarching, if you want, guideline that you can switch to the other inhibitor. It's not approved in that context. Now, there are specific situations where specific secondary resistance mutations, if your doctor is able to identify the precise reason why your tumor, let's say, was resistant to adagrasib, there are specific mutations that are non-overlapping, where you could predict that that patient would respond to the other G12C inhibitor, sotorasib, for example. But that would have to be in a very individualized scenario where the mechanism of acquired resistance has been determined. And again, that would be something that would be determined on a case-by-case basis. I don't think we can make a global.
But that would require another, either at least a ctDNA liquid biopsy, or you would need to do another biopsy to see if there was any new resistance or other biomarker mutation, correct?
We're going to talk about this in detail, but I think mechanisms of resistance, but absolutely, I think it's critical when clinical resistance to a G12C inhibitor, whatever that might be, sotorasib or adagrasib, emerges, that we aggressively pursue resampling, both analysis of circulating tumor DNA, as well as, where possible, rebiopsy of the tumor, to try to chart the precise mechanisms that have led to resistance. And this will become particularly meaningful with a broad spectrum RAS inhibitors that we're going to talk about, the Pan-RAS inhibitors or the Pan-KRAS inhibitors, because those might really be ways to overcome adaptive or acquired resistance to these first generation of state selective inhibitors.
I'll let you get at it.
All right. Okay. All right. So we've spoken about the first generation inhibitors, but it's important to know that we've got more potent G12C off-state selective inhibitors, such as divarasib. So divarasib, otherwise known as GDC 6036, is, if you want, a second generation off-state selective inhibitor, and currently, in my opinion, probably the best in class in terms of the data that we have seen. So in the phase 1 study, a confirmed objective response rate was observed of 53.4%. So that's significantly higher than what has been reported for both sotorasib and adagrasib. But the most interesting data is actually that the progression-free survival is significantly longer. Of course, it's difficult to do trial-to-trial comparisons, but the number, 13.7 months median progression-free survival, is also almost double the 7-month cutoff that we observed with both sotorasib and adagrasib. So this is potentially a much more potent inhibitor, and we're kind of eagerly waiting for more data from divarasib, perhaps directly comparing it with these first generation inhibitors, sotorasib or adagrasib. Now, what about the safety of divarasib? It's overall safe. Again, it does have some GI adverse events. I mean, they're mostly low grade, grade 1 in the majority of cases, and they can be addressed with standard of care supportive medicines. However, this does have a little bit of GI toxicity, and the rate of transaminase, the ALT and AST, the liver toxicity, appears to be about 7% grade 3 and above. So certainly monitoring liver tests is important for divarasib, as it is for the other off-state selective inhibitors. I think we need more data to understand how well divarasib combines with other therapies, and where exactly the toxicity lies compared to the other drugs. But for this drug, the impressive results is that the durability of response and the progression-free survival, which is almost double of what we are used to with sotorasib and adagrasib. Now, there are other G12C inhibitors in late phases of clinical development. One of them is GDQ443. So this is otherwise known as opnurasib. So this is the compound from Novartis. Again, in earlier stages of clinical development, the reported efficacy for this drug is interesting. I mean, the number that was cited there, confirmed objective response rate, 57.1%. Of course, the number of patients treated that has been reported is too small. So we absolutely need to wait and see more mature and advanced data in order to place opnurasib, in order to compare it, if you want, with the other drugs in this space. One important point to note about opnurasib is that the safety profile appears to be good. So rates of treatment-related adverse events, high-grade treatment-related adverse events with opnurasib appear to be lower. So if there's one feature of this drug that I think stands out, is its apparent safety. Of course, we need more data to validate this, but at least the first read of the data is that this is an effective drug that appears to have a favorable safety profile. And we also have recently seen drug with a Lilly compound, so LY3537982, that's a long name. But again, the objective response rate that was reported in patients that were G12C inhibitor naive was 38%. So certainly this is on the same broad efficacy that we have observed with the other off-state selective inhibitors such as sotorasib and adagrasib. Again, we need to see more regarding the safety profile of the drug, is again in keeping with what we are used to. Again, we need to see more to try to understand how does this compare to the drugs that have received accelerated approval in this space. Several other drugs, I'm not going to go into each one of them in detail, but as you can see, there was one from Merck, MK1084. There's the D1553, and then is glesirasib, the JAB21822. So multiple different off-state selective inhibitors in different stages of clinical development two drugs that have received accelerated approval. Divarasib, in my opinion, has so far demonstrated the best numerical, at least, efficacy in the context of an early phase trial with a 53% objective response rate and median progression-free survival that appears to be higher, but we're eagerly waiting for more data, for more robust data regarding the efficacy of these other drugs that are in different stages of clinical development. Okay, we're going to slightly shift gear here and talk about potential molecular determinants of the efficacy of off-state selective inhibitors. So why is this important? This is important because we acknowledge...
Let's first define what an off-state selective KRAS.
An off-state selective inhibitor is an or inactive state selective inhibitor. It's basically all the drugs that we have been talking about so far fall into this category. So they bind specifically to the inactive state of RAS, of KRAS, of G12C. The inactive state is the one that's bound to GDP, as opposed to the active state, which is bound to GTP. So all these drugs, for all these drugs, the inhibitor binds to the inactive state and locks, if you want, the drug into this conformation, prevents it from switching into the active conformation, which is GTP bound, which is the one that signals downstream and promotes cancer.
So it's throwing a wrench in the engine to stop it.
Exactly. But all these drugs require RAS to switch between the on and the off state in order to act. And we're going to talk about, as this is kind of will serve as an introduction to these new generation drugs that target the active state. But first of all, we need to understand what's the challenge that we're facing with the off-state selective inhibitors. And the challenge is that clinical outcomes are heterogeneous. We've got some patients that do very well and have long-term progression-free survival. And we've got some patients whose disease progresses quite rapidly after starting an off-state selective inhibitor such as sotorasib and adagrasib. And therefore, those patients might require either a different approach, either a different inhibitor or a combination. They would require some form of intensification of therapy up front to achieve a favorable outcome. So it's particularly important to try to define parameters or predictors, if you want, of distinct clinical outcomes with these off-state selective inhibitors. So we presented this last year's AACR. So this was a large analysis of 424 patients with KRAS G12C mutant non-small cell lung cancer that were treated with either sotorasib or adagrasib, very much similar to the clinical trial populations. And we asked the question whether co-occurring genomic alterations, these are genes that are mutated together with KRAS at baseline. So these are genes that you look in that genetic report, you see KRAS G12C, but it's very rarely the only gene that's mutated. There are usually other genes that are mutated. So the question that we asked here is, do certain commutations, when happening together with KRAS G12C, impact clinical outcomes with sotorasib and adagrasib? And what we found was that 3 commutations in 3 key tumor suppressor genes, these were KEAP1, CDKN2A, and SMARCA4, which together, when you look at all of them, they are found in approximately 1 in 3 patients with KRAS G12C mutant non-small cell lung cancer. Those were, when taken together, drivers of poor clinical outcomes with sotorasib and adagrasib. And they could essentially identify approximately 50% of patients that had early disease progression with sotorasib or adagrasib. Early disease progression in this case was defined as progression or death at 3 months or less. So these are the patients whose disease progresses really at the time of the first scan or at the time of the second scan, very early on. And half of those patients had a commutation in one of those 3 genes. So by knowing the status, just by looking at that report, that genomic report at the outset, we could potentially identify half of the patients that were not going to do so well with sotorasib or adagrasib alone. Okay.
And then from a practical standpoint, because it
Mhm.
sounds like bad news to me as a patient,
Yes.
I have those things, okay, and it's like, okay, now you're telling me this G12C inhibitor is not going to work so well. So what are we going to do?
Absolutely. So that's an excellent question, and we're going to come to that. So we believe that we believe that those patients need intensification in the context of clinical trials, and we've got specific clinical trials that we think specific approaches that we think might be beneficial for them. But certainly, if these patients, when I see a patient like this, I think that I should not just do sotorasib or adagrasib alone. I should try to find a clinical trial that is meaningful, and we can discuss about some of the approaches that we are prioritizing. But these are the patients that really need intensification of therapy.
Okay, so
Now,
what I'm trying to get to is that, and if somebody's listening into this conversation, okay, and they're like, oh my gosh, I have these things, okay, and I'm only on a G12C inhibitor, okay, then they may need to like up their game. They may need to push harder, okay, because of your window of time, okay, I understand OS and PFS, okay, it's fantastic when it's statistics, but if it's me and I'm that blip, okay, I'm in trouble.
I think if you're already on a G12C inhibitor and you're doing well on it, I would still I would still continue. I wouldn't change treatment. However, if I didn't know anything about this and I've just heard this webinar here and I'm looking at my report and I've got one of these mutations, I would I would be vigilant. I would and then I would I would start. I would speak to my physician about what options might be available, further down the line. So in a way, charting the path. If this doesn't work, what are we being preemptive? What are we going to do if this thing doesn't work? And perhaps, starting to explore. What options I might pursue if that is the case. I receive referrals every day about patients who have these alterations. And they're precisely in this situation. They have started with what is approved, and they may be doing well. In which case, we say continue, but be vigilant. Speak to your physician. Be knowledgeable about what options might work in this particular scenario better. And if the time comes where you need a subsequent line of therapy, then choose one of these options that we believe might take priority. The reality is we don't know yet for sure which one of these approaches is going to be better, but this is where preclinical research and all the experiments that we performed in the lab give us clues that certain approaches might be better than others in the context of these difficult to treat patient
So short
populations.
answer is get ready and have a next step plan and
Exactly.
plan for following after that. And
Exactly.
so you're ready to act fast, right?
Exactly.
Okay. And I know I really want to make sure we get to the RevMed information and all that too. So I'm gonna try and contain myself here.
Okay, all right. So this is data that was presented at this year's AACR by my colleague Marcelo Negrao. So this is basically validating what we described last year in the context of our retrospective study. This is now looking at data from Crystal 1, which was the registrational study for adagrasib. So as you can see, in the context of a clinical trial in this well-controlled patient population, mutations in KEAP1 were associated with worse progression-free and overall survival as expected. And interestingly, not just mutations in KEAP1, but looking at the transcriptional signature. So this is now looking at the impact of the mutation on the gene expression as captured by what we call a NERV2 score, which captures which is essentially what happens when KEAP1 is inactivated. This can also separate patients into groups with different clinical outcomes. So this provides significant validation for the work that we presented last year. Now, Marcelo also presented that mutations in a separate gene, in STK11, in the context of the Crystal 1 clinical trial, also appeared to be associated with worse clinical outcomes with adagrasib. So this is a slight point of divergence with slight disagreement, if you want, with what we described last year. Because last year we said that mutations in STK11 alone don't impact clinical outcomes. So if you just have STK11, you're all right. But if you have KEAP, that's the one that is the bad player that is associated with worse outcomes. But now when we're looking at this data suggests that mutations in STK11 themselves, under certain circumstances, might also be associated with worse outcomes and therefore might require treatment intensification. This is an area of intense study. We still need to understand this a little bit better. Why do some studies pick up STK11 as a player, as a group that requires, is associated with worse outcomes, and other studies don't? So stay tuned in this space. Perhaps in a couple of months, we can provide a little bit more clarity about the impact of STK11 alterations on clinical outcomes with these inhibitors. But this is interesting and important data. Importantly, as you can see in C, what Marcelo showed is that if you take all of these things together, KEAP1, STK11, and NERV2, you can identify approximately a third of all patients that don't have mutations in those genes and are NERV2 low. That's the black curve, that do exceptionally well just with adagrasib monotherapy. So you can appreciate here in the overall survival. These are patients that don't have mutations in STK11, they don't have mutations in KEAP, and they are NERV2 low. In other words, they don't have inactivation of the pathway. The median overall survival in these patients is not reached. So, and this is with adagrasib monotherapy. So just by knowing these parameters, we can immediately capture 1/3 of the total population that seem to do very, very well just with adagrasib monotherapy, and therefore may not require further treatment intensification. So these data are testament to the power of these analyses at identifying subgroups of patients, at resolving the heterogeneity of patients with KRAS G12C and trying to subgroup patients into groups with distinct outcomes, because there might be some patients that really don't need much else. On the other hand, there are clearly patients that where sotorasib or adagrasib alone is not enough and they require treatment intensification. This is another parameter that kind of may influence clinical outcomes. This is additional copy numbers of KRAS amplification, copy number gains, or additional mutations in RAS pathway genes, let's say mutations in NRAS or HRAS that may co-occur with KRAS. And in that scenario, patients also don't tend to do very well with the off-state selective inhibitors such as sotorasib or adagrasib. So this is another patient group that will require treatment intensification. Okay, so we've spoken about perhaps commutations. So in other words, things that we can pick up from a genomics report, from a genetic report, from a sequencing report, and at baseline, a priori, try to predict clinical outcomes with off-state selective inhibitors. But the major barrier to the efficacy of off-state selective inhibitors is also what we call rapid molecular adaptation. So this is a situation where you treat with a G12C inhibitor and initially the tumor responds. In other words, it shuts down signaling, but quickly signaling gets reactivated and basically MAP kinase pathway signaling is restored. So this is the basis of adaptive resistance. And this is what we sometimes, for example, see in a patient that may get treated with a drug and have stable disease as best overall response. In other words, the tumor doesn't grow, it stays stable at the time of the first scan, but then at the time of the second scan, it starts, it starts to grow. And this is the third important barrier to the efficacy of the inhibitors, which is acquired resistance. So what does acquired resistance mean? How is it different? Acquired resistance means a patient that initially responded to treatment. So you had a partial response, the tumor shrunk, and that response lasted for a certain period of time, for certain months. And then eventually one or more tumors started to grow. So this is what we call acquired resistance. It's a resistance that emerges after a period of response. So this is excellent work from both Dr. Awad, from Dana-Farber, and the Memorial Sloan Kettering group that looked at what are the genomic drivers of acquired resistance with adagrasib under A and with sotorasib under B. And the conclusion was that resistance was frequently what we call polyclonal. In other words, we did not find a single alteration that was driving acquired resistance, but patients might have multiple simultaneous alterations that are driving acquired resistance in multiple genes in the MAP kinase pathway, sometimes in KRAS itself. Sometimes the KRAS G12C could acquire, and so sometimes the patient could acquire a different KRAS mutation like KRAS G12D or KRAS G12V. Sometimes they would acquire additional copies of the G12C, and sometimes they would acquire different mutations in other components of the pathway. And this is a major problem. This is a major hurdle to overcome, because you can imagine you can potentially deal with a single mutation if you can pinpoint a single mutation, the same way that we did with Tagrisso, that was very active against T790M mutation, which was the dominant mutation in response to the first generation EGFR inhibitors, gefitinib and erlotinib. There was a single mutation that was present in 50 to 60% of cases. You're assuming that
everybody knows about other stuff besides what they have.
Yes. In any case, this is the bottom line here is that this is a major challenge, because one single drug may not be enough to overcome adaptive resistance. But the point that I want to make is that in many cases, both primary resistance, de novo resistance, adaptive resistance, and acquired resistance converges on the same process, which is accumulation of the active form of RAS, which is GTP-loaded KRAS, resulting in incomplete target coverage. So accumulation of KRAS GTP represents a point of convergence of primary, adaptive, and acquired resistance. In other words, if we can target the active state of KRAS, we might be able to overcome or forestall or prevent the development of multiple forms of resistance. So this is where we move into this new generation of compounds that target this time not the inactive state of RAS, the GDP-bound RAS, but the active or GTP-bound form of RAS. And this is where I would like to highlight this pioneering work by Revolution Medicines, this pioneering approach, which is a completely different, completely novel chemistry to develop tri-complex inhibitors of active RAS isoforms. So here you've got RMC6291, which is a tri-complex on-state selective inhibitor of RAS G12C. It targets the GTP-bound form of RAS G12C. So the drug gets into the cell. Once it gets into the cell, what it does is it binds to a protein that is present normally inside the cell. It is an abundant immunophilin called cyclophilin A. So the drug binds to cyclophilin A, it forms a binary complex. And it is really that binary complex that is able to bind to the active conformation of RAS G12C and form, as you can see here, a ternary complex. And really this ternary complex sterically inhibits interactions between RAS and its downstream effectors. In other words, prevents RAS from signaling towards its signaling partners and basically shuts down RAS signaling. So certainly very innovative approach. Would it work? So this is data that was presented at last year's ESMO 2023. This is from the phase 1 clinical trial of RMC6291, which is the G12C on-state selective inhibitor. And as you can see, the first point to note, are these drugs safe? They appear to be safe. So, the majority of treatment-related adverse events are low-grade treatment-related adverse events. One thing that worth noting here is that, there is the QTC can get prolonged. So that's one thing that we need to be careful about as we develop this drug. But by and large, this drug appears quite safe. So this is extremely encouraging. Most importantly, this drug resulted in a 43% objective response rate in patients with G12C mutated non-small cell lung cancer. These were patients that had previously not received the G12C inhibitor. But it's actually very interesting that even when the drug was tried in patients whose disease had progressed following treatment with an off-state selective inhibitor, such as sotorasib and adagrasib, the response rate in those patients was 50%. So this is very cool. I mean, obviously numbers are still small, only 10 patients, so we need to see more patients, but at least in principle, it looks like RMC-6291, the on-state selective inhibitor, is able to overcome resistance to the off-state selective inhibitors, sotorasib or adagrasib. So this is exciting. This is exciting because this drug might work not only for G12C inhibitor naive, but also for G12C inhibitor pre-treated patients.
So let me just repeat back what you just said. Okay. Okay. So what you're saying is that it was only 10 patients, 12 patients is small, right? I was 10 patients. Okay. In these 10 patients, they responded well to this G12C inhibitor as first line therapy, right?
Oh, so the ones that were first line therapy were these 7. And you can see that 3 out of the 7 had a response, so 43%. But there were also 10 patients that had previously received the G12C inhibitor, and then the disease progressed eventually.
All right, so 10 people had already received their first G12C inhibitor, but they had progression, and then they went on to this drug, which works on an on state instead of the off state.
Exactly, and 5 of them, 50% had a response.
Okay.
So this is cool. Okay. Now, this is again data that was presented at AACR. So this is kind of fresh data. So this is data about a new inhibitor called BBO8520. This is actually a dual state selective G12C inhibitor. So this inhibitor targets both the on state and the off state. Okay, so it targets both GTP bound KRAS G12C as well as GDP bound KRAS G12C. That's why we call it a dual state selective inhibitor. Now, so this was the first time that the chemical structure of this inhibitor was disclosed. So this is the chemical structure. It's the first, if you want, presentation of the chemical structure of this inhibitor. And the mechanism of action was deciphered. It acts by blocking RAS GTP in the non-productive state 1 conformation. This is a bit complicated. We don't need to go into great detail there. But what I will say is that this inhibitor, as predicted, you can see this here in D, as predicted, it inhibits RAS binding to its effectors very quickly, within minutes. You can see here, this is the green curve. It inhibits it within minutes, and it inhibits it completely. Whereas the off-state selective inhibitors, such as sotorasib, adagrasib, or divarasib, need a longer time in order to inhibit the interaction between RAS and its effector, in this case RAF, and the inhibition may not be complete, may not reach 0. So these drugs have got a theoretical advantage because they don't rely on RAS switching between on and off. It can target what's already there immediately. They can achieve target inhibition very rapidly and completely. Now, we will see whether this translates into better efficacy for patients, but this is the theoretical advantage that we observe with these on-state selective inhibitors, as well as the dual-state selective inhibitors, such as BBO8520. And you can see here that it works in xenografts, and it works in genetically engineered mouse models. So again, we need to see more data. The clinical trial, as you can see here, is open. This is again an exciting compound, and more to come. Okay. Now there is a second dual state selective inhibitors that was previously discussed. I'm not going to go into much detail about it, but again, dual state selective inhibitors from Frontiers, FMC376, another drug that I think is worth considering. Certainly, we're waiting to see more data from the dual state selective inhibitors. Okay, so now I'm going to talk about RMC-6236, which is a Pan-RAS inhibitor. And this is a compound that I am very excited about. I think the whole community is quite excited about, because so far we have been talking about mutant selective inhibitors. We separated them into the off-state selective inhibitors, the on-state inhibitors, and the dual state inhibitors, but they still only target KRAS, RAS G12C. Here, RMC-6236 is the first-in-class potent non-covalent tri-complex RAS multi-on inhibitor. This means that this targets both the mutant and the wild type forms of both KRAS, NRAS, and HRAS, all at the same time. So this is if you want a more comprehensive inhibition of RAS signaling, as opposed to just targeting the mutant, the mutant oncoprotein KRAS G12C. Okay, and these are data that again were presented during AACR. So this is fresh data, and were also published in Cancer Discovery simultaneously. So this is, first of all, the chemical structure of RMC-6236, which has now been disclosed. And here you can see the efficacy of RMC-6236 in big collections of patient-derived xenograft models. So these are tumors that, these are models that are based on a tumor. They're taken from the tumor, and then they are propagated in immune deficient mice. So you can see that when the drug was tested in non-small cell lung cancer models, and this can be G12D, G12C, G12V, G12A, not limited to G12C here, across a range of different alleles, the objective response rate here was 52%. What is more important is that you can see that these responses are actually have got impressive durability. So this is the median has not been reached. It means not only does it shrink tumors, but for as long as you continue to treat, the significant majority of those tumors don't grow. They remain suppressed. So this is certainly something, a feature of this drug that I am very excited about, and I would like to see whether it behaves in the same way in patients. Similarly, when we looked in pancreatic cancer, which is again a very aggressive malignancy, in PDXs, the objective response rate with this drug was 64%, and again, marked durability of the response. So we're certainly quite excited about this drug. Now, what about
trial that's ongoing right now, correct?
What's that?
The RevMed, the 6236. That's the ongoing trial, right?
Yes, we will. I've got a slide about the trial right afterwards, so we're going to talk about the trial. But absolutely,
that's what we're super excited about.
It's in multiple clinical trials.
I know.
But let me ask this question: what about these difficult to treat subgroups with the commutations that we spoke about? What about KEAP1, CDKN2A, and SMARCA4? So they looked at that in this array of PDXs. Interestingly, SMARCA4 appear to be sensitive to a large extent to the RMC-6236. KEAP1 and CDKN2A, they still observed slightly worse clinical outcomes with the RMC-6236 in these patients. So these are subgroups where the best approach might actually be, and we will talk about this in a little bit later, might be a combination of the Pan-RAS inhibitor, the RMC-6236, plus a mutant selective inhibitor, such as RMC-6291. And there is a clinical trial where that is testing this right now. But the hypothesis is that these tumors really required comprehensive suppression of the MAP kinase pathway with potentially a mutant selective inhibitor plus a Pan-RAS inhibitor. At least that is one possible approach to overcoming these inherently recalcitrant or difficult to treat patient subgroups. Now, one important point to note here is that this drug appeared to be RMC-6236 as monotherapy, appeared to be particularly active in patients that had the G12V mutation. So this is interesting. So this, at least when they looked at all of these models, one association that they could derive was that the G12V models appear to be particularly susceptible. So this is interesting because right now we don't have any targeted therapies for patients with KRAS G12V mutant non-small cell lung cancer. So this appears to be a particularly promising approach for this patient cohort. Okay, oops, went the other way. All right, at AACR again, we saw the first data about possible mechanisms of resistance, this time to this multi-inhibitor. RMC-7977 is the preclinical compound of RMC-6236, which is the Pan-RAS inhibitor from RevMed. So here they're asking the question, can a tumor develop resistance to RMC-6236? And if it does so, how does it do so? One important conclusion was that they did not observe this, this compendium of many different mutations in the MAP kinase pathway when tumors developed resistance to the Pan-RAS inhibitor. So this is good. It suggests that the Pan-RAS inhibitor is able to suppress these polyclonal mutations in RAS pathway components. What they did observe was that the few tumors that developed resistance here appear to have amplification in a transcription factor called MYC that is downstream of RAS. So it seems that the way that the cell can overcome, if you want, the Pan-RAS inhibition is by increasing the copy number of transcription factors that lie below RAS. So this is interesting because this is work that was published in Nature from Ken Olive's group in pancreatic cancer, but I think that this will be applicable in non-small cell lung cancer too. They identified possible combinations between the Pan-RAS inhibitor and inhibitors of the YAP-TEAD pathway, so TEAD1 inhibitors, which is a class of agents that we're all quite excited about to combine with RAS inhibitors. They identified that as a rational strategy to overcome resistance to the RAS multi-inhibitor RMC-7977. So this is certainly something that I think we will see more of in the near future. Okay, your question, what about the efficacy and safety of RMC-6236 in patients? So the first, I think, when this was first proposed, many people in the field said this is not going to be possible. And the reason why this is not going to be possible is because if you inhibit RAS in normal tissues, there's going to be a lot of toxicity and perhaps prohibitive toxicity. So the first thing, the first hurdle that needed to be overcome was safety. Surprisingly, the drug turned out to be quite safe, which is phenomenal news. When I first saw this plot, I was ecstatic. I mean, this proves beyond any doubt that Pan-RAS inhibitor, that robust inhibition of RAS is not associated with excessive toxicity in an adult organism. Now, what toxicities are observed? We observed some skin toxicity. And so that will require specific instructions about the management of the skin toxicity in the same way that people who get EGFR inhibitors were used to, skin toxicity is a common side effect of EGFR inhibition. Pan-RAS inhibition is also associated with cutaneous toxicity, but in the majority of cases, this is managed with standard supportive medications. Other things, there's a bit of stomatitis, so sore mouth, and there is a little bit of diarrhea and vomiting, but by and large, this drug has appeared much more safe than was thought that it would be. Interestingly, there was no QTc prolongation, and even more importantly, there did not appear to be any hepatotoxicity here. So no LFT abnormalities. And this included patients that had previously been treated with immunotherapy. So if this turns out to be the case, once we see more data from a larger cohort of patients, this would certainly be big news because it might suggest that unlike the other RAS G12C inhibitors, this Pan-RAS inhibitor might have a better safety profile in combination with immunotherapy. We don't know at this point in time. The clinical trials are ongoing, but that is something that I think the whole field is eagerly waiting. If it turns out to be the case, it's going to open up tremendous opportunities for combination therapies.
When you say Pan-RAS, what RASs are you including? And remember,
so this is inhibiting.
Remember, our community has more than lung. We're pancreatic.
So this is inhibiting both KRAS, NRAS, and HRAS, multiple different alleles. Certainly the common ones, G12V, C, D. It's also inhibiting wild type RAS. So it's also inhibited the wild. And why is that important? That's important because sometimes this adaptive resistance, this reactivation of the pathway occurs through this wild type NRAS, KRAS, HRAS. So this is really critical because by inhibiting not only the mutant forms that drive the cancer, but also these wild type normal versions, if you want, that mediate adaptive resistance, you're able to prevent the emergence of adaptive resistance or delay it substantially. So this, of course, was the concern that if you inhibit wild type, you're going to attack normal tissues, but that does not appear to be the case. So this drug seems to be hitting a sweet spot between allowing normal tissues to function relatively normally, and at the same time completely shutting down RAS signaling in these RAS-addicted tumors, which then undergo rapid tumor regressions, basically die or stop growing. Okay, and this is the proof of principle that this drug works in patients. So these are patients with KRAS G12X non-small cell lung cancer. G12X means mutations in the G12 position. These are not non-G12Cs. So as you can see, these are either D or V or A or S, but non-C. And in this group of patients, the objective response rate was 38%. So this suggests that this drug works. Now remember that patients treated here in this cohort were treated across a range of different doses, starting from 80 milligrams and moving all the way up. So what we really want to see is what would the efficacy look like in doses, in higher doses that are closer to the recommended phase 2 dose. Here, there was a broad range of doses, so perhaps there is room for improvement of this 38% even further. But still, I think it's quite impressive that more than 1 in 3 patients with non-G12C mutant advanced non-small cell lung cancer responded to this drug. We want to see how long this duration lasts. This is data that will come in the future, but this is very, very exciting.
Well, let me just highlight, because sometimes we're a little slower. I've still got chemo brain myself. Okay, when you're saying non-G12C, what you mean is it could be a G12A, G12C, G12A, G12V, G12D, whatever.
That's right.
Something else. Now, but that's not applicable for like the G13s or like the Q61? And does it matter?
It does have some activity. It does have activity against these other alleles as well. It's a Pan-RAS inhibitor. Now, for some of these, the activity is predicted to be less. But if the dose goes up enough, we may be able to inhibit those tumors as well. So as you can see here, in the proposed clinical trial, this is the schema for the phase 3 clinical trial that is it's still undergoing some thinking about what the exact design is going to be, but the general idea will be to do RMC 6236 versus docetaxel for patients with RAS mutated non-small cell lung cancer. And as you can see here, they are including both G12C as well as non-G12C. So G12X, but they're also including these additional mutations that you have spoken about. So the G13, the Q61, the less common mutations. So this drug holds promise for a large majority of patients with RAS-driven tumors, and that's why we're quite excited about it. Okay. I will briefly mention this. I'm not going to go into a lot more detail because we still got a fair amount to cover. There are other pan-KRAS inhibitors. So this was one that was recently reported by Pirolito in collaboration with Boehringer Ingelheim in Nature. So this is a non-covalent off-state selective inhibitor of KRAS. So this is a pan-KRAS inhibitor, not Pan-RAS. So it doesn't inhibit HRAS, NRAS, and the others, but it's a pan-KRAS inhibitor. And again, in both tissue culture as well as preclinical models, this has shown efficacy. Okay, now we're briefly going to talk about another kind of major progress in the field, if you want, and again, we saw some recent data at AACR, which is development of other non-G12C mutant selective inhibitors. So we've spoken about the G12C inhibitors. We've spoken about the Pan-RAS inhibitors, the Pan-KRAS inhibitors. What about mutant selective inhibitors of non-G12C alleles? So this one was previously described as MRTX1133. It is a potent and selective non-covalent inhibitor of KRAS G12D that is undergoing clinical evaluation. I did not see any major updates on this, but this is still undergoing clinical evaluation. And as you can see, it has worked across multiple PDX and CDX models of KRAS G12D driven cancers. Dr. Shaukat presented, again, novel covalent chemistry. So the question there is, MRTX 1133 is a non-covalent, reversible, in other words, inhibitor of KRAS G12D. Can we develop irreversible inhibitors of KRAS G12D? This is something that was thought to be difficult, in the same way like sotorasib and adagrasib are irreversible. They bind, and once they bind, it's a covalent bond, it's an irreversible inhibition. Can we develop irreversible inhibitors, covalent inhibitors of KRAS G12D? And he presented a very, again, I'm not going to go into all of this in detail, but there is significant progress in covalent chemistry that will allow the development of covalent inhibitors of KRAS G12D. However, what I do want to talk about is RMC 9805, because this drug is in clinical trials right now. So this is a compound from Revolution Medicines, again, based on the same principle, the tri-complex for formation. So this is a RAS-on, in other words, active state selective GTP inhibiting the active form of KRAS G12D. It's a G12D selective inhibitor, and it's a covalent inhibitor. And again, the structure was disclosed for the first time during AACR. You can see that this works across a broad range of preclinical models with KRAS, with RAS G12D driven pancreatic cancer, that's the green, and non-small cell lung cancer, that's the orange, and to a lesser extent, colorectal cancer. And you can see that the responses are again very durable. So certainly a very promising compound. The clinical trial is ongoing, and it was reported earlier in the year that RMC 9805 cleared multiple dose levels, and no dose-limiting toxicities have thus far been reported. So certainly, we still don't have efficacy data for this molecule, but eagerly awaited. Okay. All right. So one thing that I do want to mention here, and this is very complicated, but I will try to, this was presented by Dr. Aguirre at AACR, but I found it fascinating. And it's something that I think we will see more and more of in different settings. So this again talks about how do tumors adapt to these powerful next generation inhibitors. So in this case, they are conducting this study in mouse models. It's a mouse model of pancreatic cancer, but I think it applies to non-small cell lung cancer. That's why I'm mentioning it. And they are treating them with this G12D inhibitor from Mirati, now BMS, MRTX 1133. And they are harvesting tumors at different time points, and they are looking at not only at the genetic alterations to try to see for the development of acquired resistance, but also transcriptional changes in these cells. In other words, how do these cells change at the non-genetic level, at the transcriptional level, in response to this inhibition? And what is interesting is that tumors at the beginning are quite heterogeneous. Some of them are what we call epithelial. They look more like a normal gut, if you want, like a normal pancreas. Some of them are more spindly. They're more mesenchymal. It's a mixture. But once you treat these tumors with the RAS inhibitor, in this case, MRTX 1133, it seems that the spindly cells, that the mesenchymal cells disappear, and all the cells that survive, you can see it here, are these epithelial cells. Whereas at the time of development of resistance, when the tumor eventually grows, you start to again see more heterogeneity and a greater mixture of different states. Why is this important? This is important because it may suggest that when you initially treat with a RAS inhibitor, the cells have a very narrow evolutionary path to survive. You're starting with something that's very heterogeneous, everything is different, but once you hit them with the inhibitor, they all need to turn into roughly the same thing in order to survive. And once they do that, then they can become heterogeneous again. So that provides a window of opportunity to target those cells that are all in the same state with a second drug. What could that second drug be? Chemotherapy is one possibility, because we know that chemotherapy doesn't work well in these mesenchymal cells, but it works pretty well in epithelial cells. So this is an interesting notion where you, by giving the RAS inhibitor, you are making the cells more uniform from a transcriptional standpoint, which may present a vulnerability for hitting them with something else that might kill them. So this provides very good evidence for rational therapeutic combinations, perhaps even antibody drug conjugates might work in this particular setting. So this is more to come on this. Okay, all right, and this is again data not presented at this conference, but this is another novel KRAS G12D inhibitors that utilizes a liposomal formulation. This is one of the few studies that have reported very early clinical data with a G12D inhibitor. It's called HRS 4642. Very early data, but there is proof of principle that we can see responses with this approach. Okay, a little bit about G12V, for which we have not spoken about much in terms of mutant selective inhibitors, but there is this compound, RMC 5127, again from Revolution Medicines. This is a non-covalent tricomplex active state selective G12V inhibitor. So in the same way that we spoke about G12C and G12D, there is a G12V inhibitor. It's not yet in clinical trials, but at least in preclinical models, it has shown robust efficacy. And there was new data presented at AACR that this compound may even go into the CNS, may go into the brain, and may have CNS activity. So this is kind of something to monitor, to follow up in the near future. Another class of drugs that, again, not much presented, at least in oral presentations at AACR, but previously described, the RAS degraders. So these are a completely different class of drugs that basically degrade RAS, so extinguish RAS, use the cell's own factory or machinery to degrade proteins, to degrade RAS. And a study of this compound from Astellas, ASP3082, is currently enrolling patients. So this is certainly, if you want a different approach to targeting RAS, that also merits further examination. We're going to talk a little bit about combinations. And there are multiple different combinations of RAS inhibitors. And I'm going to divide them into three groups: combinations between RAS inhibitors and other molecularly targeted agents, such as SHP2 inhibitors, combinations between RAS inhibitors and chemotherapy, and combinations between RAS inhibitors and immunotherapy, or chemotherapy plus immunotherapy. And we're going to talk a little bit about each one of these approaches. So SHP2 inhibitors, the combination of RAS inhibitors, mutant selective inhibitors, and SHP2 inhibitors is a rational one, because SHP2 is a phosphatase that in a way controls multiple of these feedback pathways that can mediate adaptive resistance to RAS inhibition. So this is something that has been in clinical development for a number of years. This combination, there was a lot of excitement, but one of the problems has been toxicity. So many of these drugs have proven to be quite difficult for patients. However, there are still multiple combinations that are undergoing clinical development, and one of these, the combination of glesirasib plus JAB3312, has shown quite impressive preliminary anti-tumor efficacy. We need to see, so you can see objective response rates, 62.1% across all dosage groups. We need to see more about this, but this is a group of drugs and this is a combination that we shouldn't forget about, because it's if we can find a combination that is safe, this might be an effective approach. And this is again data with a different combination with a G12C inhibitor, opnurasib, JDQ443, and TNO155, that showed a 33% objective response rate in patients whose tumors had progressed on a RAS mutant selective inhibitor. Okay, so this is now the combinations. We've spoken about combinations. What about combinations between the different RAS-on inhibitors? So I'm going to focus a little bit on this, on the combination that I spoke about, the combination of the multi-inhibitor RMC6236 plus the on inhibitor RMC6291 from Revolution Medicines, because new data was presented at AACR. So interestingly, although RMC6236, which was the Pan-RAS inhibitor, showed very good activity across a broad spectrum of patient-derived xenograft models, there were some models that didn't respond so well. And specifically, as you saw, models with mutations in KEAP1 did not seem to do so well. Also, models with loss of CDKN2A had lower progression-free survival. So one idea is, can we target these difficult to treat subgroups, the KEAP1, the kind of the CDKN2A, with a combination of the Pan-RAS inhibitor, RMC-6236, and the mutant selective inhibitor, 6291. So this experiment provides proof of principle that this may be advantageous. You can see here, this is the KEAP1 mutant model, and you can see that the ON inhibitor, 6291, doesn't work that well. The multi-inhibitor works better, but it still eventually the tumor grows. When you combine both of them at the same time, what you can see, which is the brown curve, you can see that the tumor is there is complete tumor regression. And the same thing can be seen here in a second model, the NCI H2030. And this is a kind of a co-clinical trial, a mouse clinical trial, where you can see that the combination of the two drugs induced deep and durable responses in multiple of these difficult to treat models with monotherapy. So certainly, I believe that this is an approach that warrants further investigation, specifically in these difficult to treat subgroups. So if I have a patient with a KEAP1 alteration, and you asked me this question, Terry, earlier, what would be approaches that might be reasonable? I think this is a very reasonable approach to try. Among others, I think my colleague, Dr. Negrao, also assessed the impact of mTOR inhibitors together with RAS G12C inhibitors in this context and showed some preliminary evidence of efficacy. So both of these approaches are reasonable. I particularly like the combination of 6291 plus 6236.
So refresh my memory there. How far along is the RMC 6236 clinical trial?
So the RMC 6236 clinical trial, the first line study has been the phase 1/2 clinical trial across multiple histologies has been accruing patients for a long time. I expect that we will see mature data in the near future. And there are combinations with both immunotherapy, as well as the combinations between the multi-inhibitor and the ON inhibitor, which is RMC 6236 and 6291, as part of this clinical study that I'm highlighting here.
Okay, so the 6236 is an on-state inhibitor, is that right?
The 6236 is an ON inhibitor, but a multi. It's the multi, it targets all RAS.
Okay, but it's multi.
The 6291 is the ON that targets G12C. Okay. So the combination is a reasonable strategy for G12C with one of these difficult to treat subgroups with the bad commutations. Okay, this is combination with chemotherapy. We're going back to sotorasib here. We're asking, does chemo add to the efficacy of these inhibitors? And again, I have to say there are two clinical trials that suggest that this combination might have unexpected efficacy. So this is the Scarlet Japanese clinical trial where sotorasib was combined with carboplatin and pemetrexed. You can see here almost 90% objective response rate, which is very, very interesting, with no new safety signals. Similar results with Codebreak 101, again, the combination of sotorasib with chemotherapy, which in this study yielded a 65% objective response rate in previously untreated patients. So the combination of a G12C inhibitor plus chemotherapy appears to be effective. What about immunotherapy for the last few slides? So obviously it makes a lot of sense to try to combine RAS inhibitors with immunotherapy. Immunotherapy forms the backbone of the first-line treatment of metastatic non-small cell lung cancer. And multiple preclinical models suggested that when you combine immune checkpoint inhibitors with mutant selective inhibitors, you improve efficacy and induce cures. However, clinically, this combination has been much more difficult to achieve. The first one to try was sotorasib, and they tried multiple combinations with different immune checkpoint inhibitors. But what emerged was that hepatotoxicity, liver test abnormalities, ended up being a prohibitive toxicity, high rates of hepatotoxicity that precluded the further clinical development of sotorasib in combination with these with immune checkpoint inhibitors. So this was certainly a setback in the field. Now, adagrasib has fared better in terms of its combinability with immune checkpoint inhibitors. So this is data from the Crystal-7 clinical trial where adagrasib at a lower dose of 400 milligrams twice daily was combined with pembrolizumab. And as you can see, this led to an objective response rate of 49%. It is notable that the response seemed to be particularly strong in patients with high levels of PD-L1 expression on their tumors. So this is data that was updated at ESMO 2023. The objective response rate in this group of patients was 63%. So this may be a combination that is particularly relevant for patients who have high PD-L1 expression on tumor cells. And the combination, the safety of the combination appeared to be manageable. There was still some hepatotoxicity, approximately 15%, but to the extent where this could be was considered manageable. Other drugs have also reported combinations with immune checkpoint inhibitors. So this is data from the Lilly compound in combination with pembrolizumab. So this is another combination that is being taken forward in the first line setting. So the Lilly compound is also being combined with pembrolizumab. And also MK1084, the Merck KRAS G12C inhibitor, is also being combined, has also been combined with pembrolizumab, and the combination has been deemed to be safe. So this combination is also moving forward in the first line setting. Finally, we also have divarasib that has also been assessed in combination with both atezolizumab and pembrolizumab. And we've got the Crescendo 170 clinical trial where combinations of divarasib with both pembro and pembro chemo in previously untreated patients first line are being assessed. So this brings me to, and I know we're like 2 minutes ahead of time, but we've got 1 or 2 slides. So this brings me to the first line. Where are we moving? Where is the field moving? The field is moving to the first line space. So I think these inhibitors have proven efficacy in the second line space. But now I think the big question is, can we incorporate these G12C inhibitors or Pan-RAS inhibitors in the first line space? There are a number of clinical trials, phase 3 clinical trials that are assessing this in the first line space. And I would certainly encourage newly diagnosed patients with KRAS G12C mutant non-small cell lung cancer to actively seek these studies to try to push the standard of care. So we've got the SunRay-01 clinical trial, which is the Lilly compound, in combination with either pembrolizumab or chemoimmunotherapy, pemetrexed, carboplatin, pembrolizumab. We've got the Crystal 7 clinical trial that I already spoke about, which is adagrasib in combination with pembrolizumab. And we've got the Codebreak 202 clinical trial, which is sotorasib plus chemo without immunotherapy in this case, versus chemoimmunotherapy for patients whose tumors express have got a PD-L1 tumor proportion score of less than 1%. In other words, PD-L1 negative tumors. There is an additional trial that will be launched from other kind of companies. I think Merck is moving forward with a phase 3 clinical trial in this setting as well. And finally, the other frontier is to move RAS inhibitors into earlier stages of treatment. So we've been using them in the metastatic setting. Should RAS inhibitors be incorporated into surgically resectable disease setting or locally advanced stage 3 disease setting? There are a number of clinical trials that are assessing this. One is being conducted here at MD Anderson. It's an investigator-initiated study of sotorasib plus cisplatin or carboplatin and pemetrexed. The second one is adagrasib in combination with nivolumab, and there is one with divarasib as part of the multi-arm Nautico-1 clinical trial. Okay, so conclusions. I think the development and regulatory approval of covalent off-state selective inhibitors undoubtedly represents a major breakthrough. However, we've got some limitations. First of all, we're not capturing 50% of patients who have got KRAS mutations but non-G12C. And also long-term efficacy is limited by both primary resistance, innate resistance, adaptive resistance, and acquired resistance. So we need more potent inactive state selective inhibitors, and we need novel inhibitors that target the active or GTP-bound form of KRAS or dual state selective inhibitors, because these drugs may in principle overcome some of the inherent limitations. In addition, preclinical or early clinical development of multiple other mutant selective inhibitors, such as G12D inhibitors or G12V inhibitors or degraders, is also underway. We're quite excited about the pan-KRAS or pan-RAS inhibitors. They've got significant promise because, first of all, they target a broader patient population. We can target basically the entirety of RAS mutant tumors. they can prevent or delay the emergence of secondary mutations in RAS pathway genes, and they may also prevent or forestall the emergence of adaptive resistance. And recently reported data from Revolution Medicines with 6236, I think, provides proof of principle that this approach may be both safe and effective. However, there are a number of remaining or lingering questions. What's the optimal therapeutic strategy? When should we use a mutant selective inhibitor versus a RAS multi? And when should we use an on or off-state selective inhibitors? When is an off-state selective inhibitor enough? When do we need to use an on? And when should we use a combination? And how should we tailor therapy to individual patients? And I think some of the data that I've presented begins to scratch the surface of the criteria that we might employ to make these decisions. So defining the best strategy to incorporate RAS G12C and Pan-RAS inhibitors into the first-line metastatic setting is a key priority, and there are multiple ongoing or pending clinical trials. What's the optimal trade-off between safety and anti-tumor activity? How can we tailor the approach to the individual patient characteristics? Should we go all in and try to combine everything together up front, or should we be going for a more staggered approach, perhaps incorporating some of these inhibitors into the maintenance phase of treatment rather than throwing everything at once? And also, what's the optimal approach for patients with CNS metastasis? Finally, bringing these inhibitors into earlier lines of treatment is, I think, key to improving outcomes in the context where disease might be potentially curable. And of course, little is known regarding biomarkers of response or resistance to these novel inhibitors. We just saw the first data at this AACR about mechanisms of acquired resistance to the multi-inhibitor, but I think there's an even bigger field with regards to perhaps not mechanisms of adaptive resistance, but perhaps mechanisms of persistence. What makes some cells have the ability to survive in the context of comprehensive RAS inhibition, even if they are in a quiescent state, and then eventually those persisters are the cells that will fuel the emergence of adaptive resistance and tumor outgrowth. And of course, what are the optimal therapeutic combinations with novel classes of drugs, such as the TEAD inhibitors, as I mentioned here? All these are exciting areas, and I'm sure we'll be here next year with an update from AACR 2025, where hopefully a quantum leap in our understanding of how best to target RAS. We've gone a little bit over as expected, but happy to take any questions. I've got some time.
Okay, all right. Well, I hope so. I hope you allow time. So I thank you very much, and you've been very tolerant of my interrupting and asking the questions and kind of drilling down on some of the slides. So I appreciate your doing that. Top of mind, like the SOS1 inhibitors and what's going on with all that.
Yeah, I think there are a number of different inhibitors in clinical development. I think the SOS1 inhibitors, like the SHP2 inhibitors, I think the proof of principle is there, and I think this represents a very valid therapeutic strategy. I didn't have time to to go into them. There were multiple kind of abstracts on many things that I have also not covered. I think it was kind of quite difficult to walk through the posters in the RAS targeting session. It was kind of pretty difficult to take a picture of the posters. So I think the SOS1 inhibitors are also a very promising avenue, certainly worth pursuing with their clinical development. I think it's difficult to know which one of these approaches will emerge as the most promising. I think it's going to be as always, a combination of efficacy and safety. I think what I am seeing here is that I think we've got enough evidence that comprehensive, robust MAP kinase, robust suppression of the pathway is feasible and tolerated. And so how we best achieve this? Via a Pan-RAS inhibitor, via a Pan-KRAS inhibitor, or via combinations with a mutant selective inhibitor and a SHP2 inhibitor, or a mutant selective inhibitor plus a SOS1 inhibitor, remains to be determined. We do a lot of these types of experiments in the mouse, trying to combine these different modalities, both in terms of their effects on the tumor cells, but also the microenvironment. That's another important aspect that we did not cover here. Many of these SOS1 inhibitors or SHP2 inhibitors or the Pan-RAS inhibitors are expected to inhibit signaling not only in the tumor cells, but also in multiple classes of immune cells. And there may be elements of that that are conducive to improving anti-tumor efficacy. We know that RAS establishes a suppressive tumor microenvironment. There is localized immune suppression as a result of RAS signaling. So alleviation of this suppression through direct targeting of RAS in tumor cells, but also potentially through effects in immune cells, direct effects, might be advantageous in certain contexts for tumor efficacy. So this whole field of combining RAS inhibitors with immune modulatory drugs, we've only begun to scratch the surface. I mean, we have understandably focused on the PD-L1, PD-1 inhibitors because those are the drugs that are approved in for patients with non-small cell lung cancer. Okay. But there are multiple other approaches in targeting different components of the tumor immune microenvironment that might make sense logically and should be tested.
Well, and I'm glad that we've got you looking at the long game. The problem is, okay, that most of us in here are looking at right here, right now. Okay, and as much as I want to be, caring about the research for, for forever and whatever, I'm making decisions right now. And so, for example, like when you're talking about like mucinous or adenocarcinomas, is one like more as one of these treatments a better application? I mean, at that point, when you've got something, it's like, I don't care about the MAP kinase pathway, right? But what is going to be a better choice for somebody in that situation, or if it's a colorectal versus like lung and like a KRAS G12D?
Yeah, the mucinous question that you bring up is an area that requires, I think, further study. I don't think anyone knows. But I think we are beginning to get, I think we're beginning, there is a subtype of lung cancer that is mucinous, and that in many studies has proven to be refractory to different, it's a more difficult to treat kind of subgroup. It's interesting that you mentioned that. So I think that certainly some of the work that I saw at AACR is beginning to kind of and enable us to form rational hypotheses about what might work in these in these scenarios. It is interesting, for example, that in this pancreatic trial, that in this pancreatic mouse model that I mentioned, treatment with a RAS inhibitor killed off the mesenchymal cells, but not the mucinous cells. So perhaps the combination with chemo in that scenario might be more advantageous. I don't think we've got the answer to all the questions, but I think the science is not far off. I think many of these drugs are in clinical development. So we've now got a number of clinical trials with all these promising cutting-edge therapies that I would encourage every patient with a KRAS mutant tumor to actively seek. I mean, long gone are the times where patients with KRAS mutant tumors, we had nothing to offer them. Here, there is a panoply of clinical trials with active agents, and we still don't always know exactly what approach is the best one for an individual patient. But all these approaches are active, and I would encourage patients to enroll in clinical trials. At the same time, I think we're at the point in time where preclinical research, the gap between preclinical research and clinical application has narrowed. We're no longer talking about trying to understand RAS without being able to target it. Mm-hmm. A lot of research right now is focused on precisely this. I mean, certainly some of this of the research that I highlighted today, that's precisely what we're doing. We're taking these difficult to treat subgroups, the KEAP, the SMARC, the CDKN2A, and we're asking the question, what would be the most logical step? Preclinical data, for example, I showed you, suggested that combining the multi-inhibitor with the ON inhibitor might work better, at least in preclinical models, in some of these KEAP1 that were difficult to, that did not respond to either drug alone. Whether this will translate to patients, I do not know, but that's what I would encourage a patient of mine who has got one of these difficult to treat disease molecular subgroups to enroll in. So I think the gap, I think preclinical research at this point in time is directly relevant because we've got the tools, so it can inform a patient choice about which one of these approaches might make most sense. There's no guarantees, but we've got logical hypotheses here, and we've got the tools which we didn't have before.
Let me see if I'm following what you're saying. Okay, essentially, okay, because when you say enroll in a clinical trial, we're going to talk about that in just a second. But all this may be preclinical, and some of it is like just early because the ongoing studies are happening. Okay, but if I'm a patient and I'm going through and I know what I have because I've looked at my biomarker test and I look at my report and I'm being really empowered and really engaged. I'm going to go back through these slides. I'm just telling you how this is going to work. I'm going to go back through these slides and I'm going to listen to what you said. And I'm going to say, okay, well, based on this information, because I have this, 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 and this, okay, I'm going to, it looks as though preclinically I will respond better this one than that one, and then start looking at doing it with that sort of a clinical trial. Now, when it comes to enrolling a clinical trial, there's a question at the end here. Well, when it comes to enrolling into a clinical trial, because when I say naive, I really was completely ignorant about anything having to do with clinical trials at all. I thought, well, you just showed up and you say, hey, do something, okay? And they threw something at you, whatever they had laying around. I was shocked, surprised, impressed, I guess, relieved that there's like a whole protocol that's laid out, and it's the same across different centers. And then that's where the data is being compared, and then you're, as a patient, need to qualify for it. So this data that you're providing and the information on what was just recently released at AACR and ESMO and what have you over the past few months, this gives us as a patient an opportunity to say, hey, maybe this trial or that trial might be something that I need to review, whether it's with a second opinion doctor like yourself or somebody else, or at your local clinic. Am I making sense?
Absolutely. Absolutely. I think I think what this requires is a strategy. What am I going to do? First of all, get the best possible opinion up front. But again, up front is sometimes difficult because many patients are in urgent need of treatment. So sometimes you have to start sometimes not every patient has the time to get many opinions. So sometimes you have to start. But I think it's important to be aware that we are at a point in time where RAS is targetable. There are more than one treatment options. There are a number of different drugs, some of which I highlighted here, many of which I highlighted here. And all of these are interesting, promising drugs. And there are clinical trials in every disease line. So previously first line, previously untreated patients, there are clinical trials for them using these agents that I highlighted. And then even if you can't get on that clinical trial, it's important to have a game plan about, okay, what is my molecular profile? Does it look like I'm in one of these groups that do better, or does it look like in one of these groups where things may not work that well with a single agent standard of care treatment? Let's use that time to get a second opinion, or let's line up what would we do, or let's discuss with my primary oncologist what would be the game plan if my tumor started to progress. And in many cases, being proactive. Also with regards, sometimes it's little things that prevent people from getting into clinical trials, like you're on a drug, or your kidneys are not working so well, or you and many of these are to some extent correctable. So I think it's important to be proactive. I think to be informed and to be proactive and to advocate for yourself. and to when you don't have the information, actively seek it out. I mean, through KRAS Kickers. I mean, this is what we're doing here. We're providing this resource, this information. This is available to everyone. I think that's what I would advise every patient around the country. This is not going to be a one approach and then one hit, one line of treatment, and that's it. Here we've got a strategy. We need a plan about what we're going to do first, what we're going to do if that doesn't work. I usually tell patients we're going to do this first. If this doesn't work, we're going to do that one. So, and we make a plan about that. Therefore, this is when I want you to come back to see me back then. And, this is what you'll do with this is, what you'll do with your local oncologist. We need to monitor this carefully. There are options. So we didn't used to have options. So right now it's absolutely critical for patients to be aware that these options exist, seek them, insist, and make the best that they can do to be as well as possible, and have access to these treatments. Which one is going to work best, we still don't know, but we've got multiple that are looking promising.
I mean, there's no guarantee, okay? And you're like, well, look where things were 5 or 10 years ago. Well, to be honest with you, 10 years ago, I didn't know I had lung cancer. So there's that. Okay, so I just have to make the best decisions based on the information that we have right now today. And and so let me hit you with just a bunch of questions, because I've been sitting here and I've been trying to behave myself the last few slides, and as promised, you brought lots of slides. So is there anything else, okay, as far as like what we need to be looking at when it comes to, say, and I'm going to hit you with a bunch of them. Okay, so no long answers, okay? So is CAR T an option? Is there a place that radiation falls in this? What happens with mRNA? Where are these other things that are going? Because these are the things that we hear about and we know that they're promising, but we're in it right now.
Yeah, it's a good question. There's no simple answer to all the questions, but let's say radiation always plays a role. I mean, we incorporate radiation mostly in the context of disease consolidation. So let's say you have been treated with sotorasib or adagrasib, which are standard of care drugs right now, and your tumor has shrunk, and you're left with a very small nodule where the PET scan says there's still likely tumor in there. So the concept of local consolidation using radiation to destroy that particular spot when we have managed to inactivate most of the disease, I think is a principle that most oncologists would recommend. So radiation does still play a role. Obviously, it plays a role for symptom control as well. If there's pain in a bone site, I mean, that radiation is pretty effective at alleviating that. And it plays a role sometimes when there's brain disease, and because despite these drugs having some activity in the CNS, if you've got multiple brain metastases, most patients need to have radiation or surgery, to treat the brain disease at presentation. So radiation plays a role for sure. Now, CAR T cells, all these approaches are they're interesting. And for, the answer is, we don't know yet. There's no CAR T approved for solid tumors at this point in time. All of these approaches, the bispecific antibodies, the CAR Ts, are adoptive cell therapy kind of approaches. Antibody drug conjugates, a different kind of strategy altogether. They all have strong rationale supporting them. Whether those would work specifically for patients with KRAS mutant tumors, it's difficult to predict. There are a number of directed immunotherapy approaches against patients with KRAS mutant tumors that are worth exploring. So it's difficult to recommend a specific one or specific trial here. But I would say that these immunotherapy approaches are certainly worth considering when you've tried other things and they haven't worked. so I would certainly encourage patients, if they've, if their disease has progressed with other lines of treatment, I would certainly give these a go. But how how you would prioritize each individual trial, it would depend on the trial and the patient.
Okay, for sure.
So that would have to be a more individualized kind of decision. Same with vaccines. I mean, vaccines are very interesting kind of approach. There is some understanding in the field that vaccines work best in the context of limited tumor burden. So perhaps not in a patient who has widespread metastatic disease, lots of tumor on board. That would probably not be the scenario where I would advocate for a vaccine-based upfront approach. But in the scenario where, the treatment, someone has had minimal residual disease, so to speak. I mean, that is a scenario where trials that incorporate vaccination make sense. And I think this is the kind of the setting we don't know, but this is an area where I think a lot of people believe that this might, vaccination might help.
And for the record, we had just a couple of weeks ago, a month ago, we did the KRAS Kickers event, and when Dr. Kristen Marone from Hopkins presented specifically around the vaccine. And, it's, again, a lot of it is, it's great, it's evolving, it's starting to happen. It's just not happening anywhere near fast enough. We can all agree on that. Okay, we are all looking for safety and durability and livability. Honestly, it's really livable. They call it quality of life, and you're like, oh yeah, well, it's just like grade 2. And it's like, let me tell you what, I've lived with grade 2 fatigue, and I can't take a shower. I'm too tired. So that's kind of what that looks like in the real world. So yeah, okay. So let me hit you up with a couple other questions, because we've got a lot that happened. And G12V seems to really be picking up steam. And this RMC, all the RevMed drugs, actually, all the RevMed, the 6236 and what have you, they're all really they're very busy. They're hard to get into. Is that pretty true?
Yes, and no. I think that careful planning ahead of time is kind of important here. I think it's always difficult. It's always more difficult to find a trial when you need it right now, and the tumor is growing, and then you have to move between centers, and you get scans on each one, and new appointments. There are inherent delays in this process which might limit eventual access to it. So I think here part of what I'm advocating for is a game plan from the very outset. We look at the patient's tumor, individual situation. Some patients are not good candidates for clinical trials, so we have to think differently. Some patients cannot have immunotherapy, so automatically certain options apply, others don't. Looking at the risk profile of an individual patient. What about all these commutations? Do we have brain metastasis? Do we not have brain metastasis? Having a plan at baseline is what I would advocate for, and then that gives you the best chances. And then I can advise patients when I know that we've got this shared strategy. I can tell them, look, it looks like that trial is going to be available, or we're going to have that for you, or that is going to be available.
Okay, so let's say we did the best we could strategically, okay, and the cancer just took on a mind of its own, okay, and that's kind of usually where it kind of goes, right? I mean, that's the sad truth. Okay, so like, how can I help mitigate that, or how would I just sit back and is it okay to get a third opinion? Is it okay to keep going back out and keep looking at this clinical trials list as the data keeps coming out? And it's qualifying for these stupid things. It's really hard. It's really hard. And it's not just qualifying, but qualifying and finding it and getting the information. And so, I mean, people that are already participating in this conversation, they're already very informed. They're already, they know about us, right? Okay. And hopefully this information will be spread out. But at the same time, it's like staying on top of it, right? At some point in time, our options are slowing down. Okay.
No, absolutely, and what you raise is not an uncommon scenario, and in many cases, in some cases, although you may want to, I mean, I would always advise you to get another opinion if you're not happy with the opinion that you got. But sometimes, it's practically difficult because the disease is progressing. So it's kind of it's important to get started. It's important to get started with something. But hopefully, part of what we're doing here and part of the education approach, that at least you know where to, when you look for the second opinion, you know where to look for, and at least you can ask Terri, what would you advise me to do, kind of in that who should we ask, so it's it's important to get the best opinion possible, but there is also a timely element to this. And sometimes I see patients move between hospitals, and during this time their cancer grows. And there have been some cases where I tell patients, look, I would love to treat you, but we need to kind of get going here, because your tumor is growing. So it's important to do this, seeking alternative opinions, but in a timely kind of fashion, and try to
and it's not necessarily in the timely fashion, it's in an intentional fashion.
Yes, correct.
Being very intentional about it, not just up front, but and using these windows of opportunity that we have. And we don't even realize what a window it is until it's shut, truthfully. And that's a lot of what we talk about. So let me hit you with a couple other questions. You've been very, very generous with your time, and I so appreciate it. Okay. But so all right, I'm going to read through some of these links that we've got here posted in the link in the chat. Okay. If somebody's got a grade 3 liver issue and they're on an immunotherapy, should they just, what would you suggest they do? They lower the dose, they take a break? Is that, indicative that they're not going to be responding? I mean, what kind of context can you give us?
You mean a grade 3 liver toxicity while they're on a G12C inhibitor, or while they're having immunotherapy?
While they're on an immunotherapy.
Without a G12C inhibitor, right?
Let's make it simple. You get a simple question. Yes.
Okay.
They're not on an inhibitor.
Yeah, usually when you hear grade 3, for most of us, grade 3 suggests stop the drug. So it's extremely rare that someone is going to have a grade 3 toxicity and you're going to be continuing the drug. So if it's reached grade 3, usually we hold the drug. Now, if it's on immunotherapy and someone has had a grade 3 toxicity, most people would also prescribe immunosuppressive therapy, steroids in the first instance. And I would prescribe steroids. I would refer the patient to a hepatologist to make sure that we've got that additional opinion and expert advice. And usually what will happen is that the lab tests will be repeated every couple of days until we are happy that the liver tests are going in the right direction. And then we will monitor them until they reach grade 1 or return to normal. And then after a certain time point, once we're confident that they're moving in the right direction, we will start to taper down the dose of the steroids. Now, while the steroids are going down, sometimes the liver test can start going up again. So it's particularly important to keep a close eye on this. I usually do it in consultation together with a hepatologist, but typically we would stop the drug, we would initiate immunosuppressive therapy, monitor very closely, and then whether steroids, whether immunotherapy can be restarted or not, it really depends on the circumstances. Typically we try not to start it immediately. There have been some cases where I have, when I felt that that there was nothing else that we could do. But the general concept of restarting immunotherapy after a grade 3 immune-related hepatitis is technically you should not. But there have been some cases where I have, if I felt that the patient really needed it. So that is a situation where you need to be very careful follow-up with your physician, and what happens in the long run is
because sometimes it feels like, as a patient, okay, just be real, all right, as a patient, sometimes it starts feeling like they're just taking blood just because they don't know what else to do with me. And and I know from looking at this right? That it is being monitored and it is justifiable, okay? But we do need to stay on top of it, and there is a reason for it, even though it's just a blood test, okay? I mean, any more than, I'm watching the, on the airplane, like, what do I do in case this happens? Because at some point in time, if that actually happens, I want to know what to do.
I know, absolutely. And especially with immune-related adverse events, this is something that, I mean, you can't always predict the clinical course. So I think it's kind of quite important to be monitoring very, very carefully, especially with liver tests. I always monitor
Okay.
quite
Right. And
carefully.
then have you seen a difference when you lower a patient's dosage of their G12C inhibitor? Is it just as
Yes. I mean, sometimes in many cases it does resolve. In other cases, you get a recurrence. I mean, it's not one size fits all. But yes, if I've got a grade 3 toxicity, a grade 2 toxicity, and then I would typically reduce kind of the dose and and kind of restart, and then we will see we will see what happens. Again, I will keep a very close eye. But sometimes dose reduction is the right thing to do, and you can go down several levels. But there are situations where every time that you rechallenge, the liver tests go up. Switching G12C inhibitors is something that can be done in those kind of cases. We spoke about it. But there are some situations where, unfortunately, we just kind of hold treatment, or we need to change altogether.
Okay. And so you can, but what I'm hearing you keep saying over and over again with all these lovely disclaimers is, as we're going into a personalized medicine approach, we really need to take everything into consideration within that individual patient to make the best decisions. And I mean, as wonderful as the slides are and what have you, I mean, we still kind of like are looking at general trends in order to make decisions based on the best possible information for what we have and where I fall approximately within that grade. Would that be fair?
I absolutely. I mean, I truly believe in a personalized approach, and that sometimes means sometimes you have to make tough decisions. I mean, we all follow guidelines, and the guidelines exist to be followed. I mean, they're based on kind of on best possible evidence at that point in time. Sometimes guidelines change depending on new evidence that comes forward, but we all have cases in our clinical practice where for a very individual case, we have done something slightly different, or we have interpreted the guideline a little bit differently depending on the patient that we see kind of in front of us. Because we feel that is beneficial for the patient. Whenever I try something, I always do it very, very carefully, and I believe that that's the right thing to do. I don't have a rigid approach to patient management. We all follow guidelines, but I think it's important to when you're dealing with a patient in front of you. So sometimes, and that's the only drug that can work for them. There's nothing else. It's worth having an honest discussion, and sometimes trying something is the right thing to do.
Well, I appreciate this, and I know you've gone way over time, and you've been very, very generous, and I know that there's probably more questions in here as well, and I ever so appreciate everything that you've done and being able to answer the questions and what have you. Am I going to see you in Austin?
Yes, absolutely. I'll be in Austin.
You're going to actually get to hear me talk this time.
That's right. Thank you so much, Terri. It's an absolute.
Thank you so much, and I appreciate it. And thank you guys all for being here and joining us. And Dr. Skoulidas is at MD Anderson, and by all means, he's always ever so kind with his time, his generosity, and his intellect. So, thank you all for joining us. Okay, we'll see you soon. Okay, bye.